So I think ankle fractures have been treated for ages, and they have all mostly given us good results. But there are a certain uh, subset of these fractures which I guess need a bit more detailing, and that's what we would like to kind of underline in this next 10 to 15 minutes. So just briefly, in ankle fractures, there is injury to the bone and or to the ligaments. So medially, there is the medial malleolus and the deltoid complex. That's number one. Laterally, there is a lateral malleolus and its lateral ligaments. There is then in between the anterior tubercle and the anterior syndesmotic ligaments, and posteriorly, there is the posterior tubercle and the posterior syndesmotic ligament. That's 3 and 4. So in ankle fractures, the current concepts is like as in the knee or in the wrist, there are two columns. Like there is a medial column, which is the medial malleolus and the deltoid. Again, the deltoid has two components, very important to understand them. There is a superficial component, the three components, which are like the tibio-navicular spring, tibio-talus, and the tibio-calcaneal fragments, and the deep, which is the anterior talotibial ligament and the posterior talotibial ligament. So superficial component prevent the eversion stresses, and the deep component are the ones which are more important and tether the talus and prevent it from subluxing in the ankle joint. So the posterior talotibial ligament is the most important and the sturdiest ligament, which is what decides the medial stability. Coming laterally, the lateral malleolus, the lateral ligaments, the ATFL, CFL, and the syndesmosis, which is the AITFL, that's anterior inferior tibiofibular ligament, and the introitius and the posterior inferior talofibular ligament, tibiofibular ligament. So these are what primarily compose of the two columns, and a new concept which is of the ankle stability, which is called the ring concept, which if you kind of look at the ankle, it has a ring which is made up of the two malleolus, the deltoid, and the syndesmosis. So whenever there is a break in one part of the ring, it is stable. But when there is a break of two or more components, it's unstable and it can be subluxed or dislocated. So understanding the full extent of injury, including the ligaments, syndesmosis, and the significance of the posterior malleolus is essential for correct diagnosis and decision making regarding treatment. Now, ankle fractures generally are referred to as malleolar fractures. They are intra-articular fractures. So bi and trimalleolar fractures are unstable and need fixation. So these must be distinguished from a pylon fracture, which are high energy injuries usually caused by impaction of the talus. So it's like a mortal and pestle effect, impaction of the talus on the distal tibia. So which classification is most important? Now there is Weber's, which is A, B, and C. Then there is AO, and there is age-old Log-Hansen classification, which is actually from 1950, but it's old, it's not validated, but and may fail to accurately describe and classify all fracture patterns. But this classification, according to a recent paper from 2015, accurately predicted the ligamentous injury in 94% of cases. And it is still useful because it makes us think about the fracture mechanism. It predicts the hidden injuries which normally an X-ray, a standard X-ray would not kind of unveil us, and it may guide us in management. So according to this Log-Hansen classification, there are 4 types. One is supination adduction, supination external rotation, pronation external rotation, and pronation abduction. So terminologies are like supination, pronation depends on the position of the foot as it rotates around the subtalar joint, and initial position of the foot is the supination or pronation, puts one side of the ankle under tension, and the rotation of the talus on the transverse plane gets you the adduction or the abduction, and the external rotation axis of the tibia. So supination, force starts laterally, and in pronation, force starts medially. So the deltoid and the medial malleolus starts getting injured first. So considering this supination adduction injury, the force starts laterally, goes medially, and you see a supra, or rather you see an infrasyndesmotic lateral malleolus injury followed by a medial malleolus vertical shear. So that's how it goes. In a supination external rotation, again the force starts at the anterior inferior tibiofibular ligament. It starts rotating outwards because it's external rotation. You get a fibular fracture which is transsyndesmotic. The force further progresses further and may have a posterior malleolar component, that's supination external rotation. Third component, that's posterior malleolus. If the force still continues, you may have a medial malleolus or a deltoid injury. So it is an SER4 injury where the deltoid is also injured. In a pronation abduction injury, it starts medially where you have a deltoid or a medial malleolus fracture. Then you have a syndesmotic injury and you may have a comminuted fibula, which is like a pronation abduction injury. In a pronation external rotation, again, you have a medial malleolus or a deltoid, like a medial column injury first, going on to syndesmosis, and you'll have a suprasyndesmotic fibula fracture. If you understand these mechanisms, you will understand how the forces have kind of transmitted through the ankle, where you can predict which ligaments are injured and how you need to treat them if you have to kind of get optimum outcome. So how to simplify this log Hansen? Look at the medial malleolus first. If it's a vertical, then it's a supination adduction injury. If it is horizontal, oblique, or no fracture, it's the remaining three, where it's supination external rotation, pronation abduction, or pronation external rotation. If you see a transsyndesmotic oblique fracture, it is supination external rotation. If you see a suprasyndesmotic fracture, it's a pronation external rotation. And if you see a comminuted fibula fracture, then it's a pronation abduction injury. So first look at the medial malleolus, then come at the lateral malleolus or the fibula fracture, and you will have which mechanism of injury have you kind of got into. So non-operative treatment of this, yes, it is possible in stable fractures. Like example is isolated minimally displaced lateral malleolus with no medial injury, which is classically seen in a supination external rotation 2, which is like where the fracture of the force has stopped at the fibula and has not gone further behind posteriorly or medially. So these are inherently stable fractures which can be treated in a cast and allowed patient to bear weight on it. So indications for surgery are displaced fractures and unstable fractures. So there are 5 things that you need to look at in an ankle so that your fractures don't get complicated and you can treat them as simple fractures. So coming first to medial malleolus, a very important factor which you need to look at is the supination adduction injury, where there is a vertical shear of medial malleolus with marginal impaction. This is the fracture, and you need to disimpact and restore the articular surface. It's very important that when you disimpact it, there might be a void in the metaphyseal and you may have to bone graft it and put an antiglade plate. So medial malleolus, be careful about the vertical shear fracture and the marginal impaction of these medial malleolus. It's very important that you don't take it lightly, these fractures of medial malleolus. Coming next, going behind. So I'm going in a reverse direction where I'm going from medial to posterior, then I'll come lateral and then come back to the deltoid and complete the entire ring of injuries. Going to posterior malleolus, it's very commonly seen in supination external rotation injuries where the third component has been, force has hit the third component where it's the posterior malleolus. So posterior malleolus was first classified by Haraguchi into 3 categories, but this classification didn't have much clinical application and it failed to kind of explain us the pathomechanism or how to approach these fractures. So Mason in 2017 kind of described this further and classified into type 1, which is more like an PITFL avulsion, type 2, which there is a bony fragment, but it's a rotational pylon, and type 3, which is more of an axial loaded pylon. The advantage of this classification was that it also told us in each subcategory whether there was a syndesmotic injury and how to approach all of these injuries. So in type 1, there is a significant syndesmotic injuries because the avulse fragments has a bigger chunk of PITFL, which is the posterior inferior tibiofibular ligament avulsion, and that's why it is inherently an unstable fracture. Type 2 is more of a rotational pylon where again the syndesmosis might be injured in these fractures, and you may have a low or a fibular fracture which is low oblique or a long oblique fracture. Going next to type 3, which is an axial loaded pylon. So where again there is lesser chances of syndesmotic fracture and the fibula fracture. Along in this classification, it also predicts how many of these injuries would have a deltoid injury or how many of these injuries would have or what approaches to be taken in this. So in type 1, what it needs is, it doesn't need to fix these injuries. What it needs to be done is it needs syndesmotic fixation. Type 2A needs an open reduction internal fixation with a posterolateral approach. Type 2B, where there is a posterolateral and a posteromedial fragment, you need to again do an ORIF depending upon which is the bigger chunk of bone. And in type 3, you need more of a posteromedial approach for these posterior fragments. So method of fixation of these posterior malleolus can be screws, which can be antegrade or retrograde, or it can be done with a plate where you need to kind of reduce the intercalated fragments and put an anti-glide kind of a plate to reduce this. So you need to fix the posterior malleolus. Yes, the outcomes of posterior malleolus or a trimalleolar fracture are slightly worse than a bimalleolar because there is more chondral damage. You need to fix all of them whenever there is instability of the ankle, where there is a talus is subluxated posteriorly and not reduced by your bimalleolar fixation. You need to go in and fix the posterior malleolus. So there is also a big school of thought that fixing the posterior malleolus restores the syndesmosis integrity, which is because a big chunk of PITFL is attached to this posterolateral fragment, and getting it back into anatomical position restores the tension of the PITFL. And also you need to reduce large intercalated fragments or joint impaction fragments. You need to fix them. Coming to the third important component of this ankle fracture, and which is very complicated rather, is the syndesmosis, which you see in supination external rotation or pronation external rotation, and also in a pronation abduction injuries like these. So it's an unstable syndesmosis. There is an equivocal instability or at-risk injury pattern, which we just described. So how do you check for them? There is a medial clear space which is widened more than 4 millimeters, or the tibiofibular clear space of more than 5 millimeters in an AP view is what you need to look at. MRIs can also be diagnostic, where it can show you what component of syndesmosis is rather injured. How do you check intraoperatively? Is you can do a hook test or a spreader test as shown in the pictures. Excessive mobility of fibula is what kind of tells you instability. So you need to check it in two planes. One is the coronal, which is you can check by putting the spreader. You can also check in the anteroposterior plane by doing a kind of a shifting test, holding it with a kind of a bone lever, and the talus shifts on external rotation stress test. The best way to reduce them is to directly visualize them. You need to slightly expose the fibula anterolaterally and make sure that the fibula is sitting snugly into the fibular incisura of the distal tibia. So this is what the Weber sees syndesmotic instability, intraoperative hook test, and once you passed a screw, this is how it looks like. There is a controversy of like whether it should be 3 cortices, 4 cortices, 1 screw or 2 screw. It all depends on surgeon preference. As long as the syndesmosis is appropriately reduced, that's what is most important. The screws might break, it may need removal, not removal. That's all again further point of discussion when we come to it. The key part is the fibula sits around 10 to 15 degrees posteriorly to the tibia. So while passing your screws, your angle at which your screw should be directed should be around 20 to 25 degrees anteriorly from posterior, as shown in the top picture over here. So the next part of the ankle talk is fibula fixation. It's seen in all types of ankle malleolar fracture. This is the most important malleolar which is kind of fractured, all the types. And most important thing, it can be fixed in n number of ways with an anti-glide plate. It can be, if it's a transverse fracture, you can pass an intramedullary screw. You can put an plate, normal AO type plate. But most important thing is you need to get anatomical reduction of fibula, which is crucial. The point where it kind of gets lost is in a long oblique or comminuted fractures, where you cannot get the longitudinal or rotational length, and malreductions of fibula are very difficult to detect. So the way to do it is you can have a look at the Shenton's line of the ankle, which is drawn over here, and there is also a dime sign, which is like if you put a circular penny or like a coin, it should be congruent with the distal end of fibula and the talus lateral process. So it's very important that you get them to length and proper reduction and fix it properly. In osteoporotic bones of fibula, especially in diabetic, the new technique of fixing is pro-tibia fixations. And that's what we do over here, where there are multiple syndesmotic screws that are passed, and it's more like a stability than where you want the bones to unite and not crumple and not the implants to break down. Lastly, the fifth point of the ankle is the deltoid. Again, a huge controversial point where it's seen in supination external injuries, the pronation external rotation, and also in pronation abduction injuries like this. Uh, the old school of thought was that whether routine medial repair is not needed and explore the medial side if reduction is not anatomic. But you need to understand that the stability is of the entire ring, and if you don't address it, or if you leave more than one component of the ring as broken, you are more likely to cause instability in your ankle, and results will be suboptimal. So in pronation external rotation or pronation abduction injuries, these are unstable where there is two components of the ring being broken and it needs fixation. In supination external rotation injuries, where the real controversy arises, where if there is only a partial component where only the lateral column is affected and medial column is still intact, it does not need to be surgically operated and it can be conserved or it can be treated non-surgically. When it affects the medial deltoid also, or rather a medial malleolus or the medial deltoid, or which is called the malleolar equivalent, it becomes an unstable and needs fixation, and you need to kind of address it so that you can get it to a stable fixation. So how does one assess stability? By either stress x-ray or weight bearing x-ray. Now again, up till now, all this time, what we used to do is the weight gravity assisted stress x-ray along with tenderness is what we used to look at. So gravity assisted stress x-ray is taken by hanging the foot on the edge of the table in a lateral decubitus, and this is how you look at by taking the AP. The weight of the foot kind of subluxes the talus outside and tells you whether there is a deltoid ligament injury along with the fibular fracture. Fibular fractures are easily seen on an x-ray, but this is what we are looking at. But if you ask the same patient to do a standing weight bearing x-ray at 7 to 10 days, you see that these are not actually subluxed, and they are quite they are not greatly subluxed or out of position, and they come back in position. So whether these are inherently stable or inherently unstable, that's what we need to look at. So to understand this corollary, we need to understand how the deltoid ligament complex is, as we just discussed. There is a superficial component which prevents eversion, but the deep component is what tethers the talus back into the mortise. So the deep component has an anterior tibiotalar ligament and a posterior tibiotalar ligament, which is lax in plantar flex position. So this, when you do a gravity assisted stress view, the foot is invariably in plantar flexion, and this PTTL, which is lax, allows the talus to subluxate outside. While when you do a standing x-ray, when the patient is in plantigrade position, the PTTL is taut and brings back the talus back into the mortise. So this is a very important concept, that you check for deltoid insufficiency, or not just the injury, but whether that injured deltoid ligament is insufficient by testing it in a plantigrade position and not in plantar flexed position. So in supination external rotation, which is a new subcategory, 4A is a stable injury because the PTTL is intact, and supination external rotation 4B is an unstable injury where even on a gravity or even on a standing weight bearing x-ray, there is subluxation of the talus, and these subset or this smaller subset of injuries need to be fixed, and not all, because we have seen that almost 20% of patients who have been operated have further implant related complications. So if your ankle is stable or deltoid is working in a plantigrade position, it is deemed to, or it is supposed to be considered as a stable deltoid, and not all deltoid injuries need to be operated or approached surgically. That's why stress x-ray, that is gravity associated stress x-ray, always overestimates a deltoid injury. So my take home message is assess and take care of soft tissues very carefully. Understand the mechanism of injury, which will facilitate your ability to reduce the fracture. Understand it via the log Hansen's classification, which also predicts ligament injuries. understand the ring stability, that's the medial and the lateral column with their intercalated ligaments, always achieve anatomical reduction for bones, especially medial malleolus impacted fractures and long oblique fibula fractures, which you should kind of get rotational stability or rotational anatomic reduction also. Be aware for potential for syndesmosis and deltoid injury, identify them appropriately and treat them correctly. So taking these concepts further, I would like to discuss a small case, discuss a case which was about a 28-year-old male had a fall in Dubai. He was operated there and brought back over here. Now, if you look at this, this was his post-op X-ray. Again, there all the components that we've just spoken about. There is intercalated impaction over here, which was not appropriately reduced. The syndesmosis is still wide. The fibula is not brought back to length. It is shortened. If you put a dime over here, it's going to be shortened. If you look at the CT scan on the axial cuts, here, if you look at, you will see that the posterior malleolus is out. It's not reduced, and the syndesmosis screws or the syndesmotic stabilization, because it's not yet brought in place, it's kind of still not functioning properly. So this ankle, in spite of it being fixed, is not reduced, or rather is still subluxated. So taking this further, we had to revise this. So looking at the pre-op or the pre-first surgery or post-first surgery, pre-second surgery, what we had to do is do all of this back again. We brought the fibula back to length. If you look at now, it looks back to length. The rotational profiles, the rotational long oblique fracture we had to do, and interfrag screws with a 2.7 screws, and then put a long LCDCP. We brought the medial malleolus back, and we put some bone graft over here, locally harvested from distal tibia, and put a sturdy implant over there. Fibula or the posterior malleolus, which was not properly fixed in the first surgery, had to be brought down, brought and put a buttress plate over here to hold the fibula back. So getting this further, getting a post-op CT, this shows that the syndesmosis now is appropriately reduced, and this is how it looks. So these are my syndesmotic screws. So now this, you see, it's a congruent reduction anteriorly and posteriorly. And this is how at 25 degrees anteriorly, you need to pass your syndesmotic screws. So again, if you understand that all the columns, medial and lateral, and the ligaments, then I think your ankle fractures, which are up till now always been told to be like simple fractures, like your normally JR2 gets to do them. It's not always simple, and you need to kind of treat them or understand them correctly to treat them appropriately. Thank you, sir.